This is the third recording for week 3. This PowerPoint will introduce manual muscle testing to you. Muscle strength is used to determine the capability of muscles or muscle groups to provide stability and support. The structure of muscles determines the muscle's action and how it responds to stretching and strengthening. Some causes for muscle weakness include nerve involvement, disuse atrophy, stretch weakness, strain, and fatigue. The primary purpose of manual muscle testing is to diagnose musculoskeletal conditions and diagnose neuromuscular conditions. Musculoskeletal conditions can cause patterns of muscle imbalance because of poor postural alignment, and this can account for pain and further muscle imbalance. Neuromuscular conditions can be due to weakness, and that this could cause asymmetry, or it can be a symmetrical loss of strength. Muscles distally will be weak with peripheral nerve injuries, and there usually are definite patterns of involvement. This is why we talk about muscle myotomes. And there can also be spotty patterns of involvement. We're going to review muscle classification. Class 1 are one-joint muscles. This includes the deltoid, the pectoralis major, the gluteus maximus, the iliopsoas, and the soleus. Class 2 muscles are two-joint muscles that act like one joint by shortening over both joints simultaneously and exhibiting maximum strength at the end range. Examples include sartorius, anterior tibialis, posterior tibialis, peroneus longus, and brevis and tertius. Class 3 muscles are two-joint muscles that shorten over one joint and lengthen over the other joint to provide maximum contraction at mid-range of overall length. Examples include the rectus femoris, the hamstrings, and the gastrocnemius. Class 4 muscles are two-joint or multi-joint muscles that physiologically act in one direction but are prevented from overshortening by the coordinated action of synergistic muscles. Examples of this include biceps, finger flexors, and finger extensors. There are 3 types of muscle structure. Fusiform muscles are the most vulnerable to stretch. They are arranged parallel to the line from origin to insertion. An example is the tibialis anterior. Pinnate muscles are the least vulnerable to stretch. A unipinnate muscle has the fibers inserted obliquely into the tendons that extend the length of the muscle on one side. An example is flexor hallucis longus. Bipinnate muscles are fibers that are inserted through the belly of the muscle. Examples are the rhomboid major and the trapezius. Fan-shaped muscles are the third type of muscle structure. Each segment is independent in that it has its own origin with a common insertion. Examples are pectoralis major, gluteus medius, and gluteus maximus. We talked about active and passive insufficiency in the last PowerPoint. Passive insufficiency refers to lack of muscle length, and active insufficiency refers to lack of muscle strength. I'm going to talk about the basic rules of procedure for performing manual muscle testing. First, the patient must be positioned in a position that provides the best fixation of the body as a whole. This is usually prone, supine, or side-lying. Secondly, the proximal part needs to be stabilized. When testing muscles of the hand, the PTA should stabilize adjacent joints to the part that is being tested. Number 3, place the part to be tested in a precise anti-gravity test position to elicit the desired muscle and aid in grading. Number 4, if a muscle is too weak to function against gravity, use test movements in a horizontal plane. If body weight offers sufficient resistance, place trunk muscles to be tested in an anti-gravity position. Number 5, apply pressure directly opposite to the line of pull or the muscle segment to be tested. Number 6, apply pressure gradually but not too slowly, allowing the subject to get set and then hold. Apply uniform pressure. Number 7, use a long lever arm if possible, unless contraindicated. Number 8, use a short lever arm if the intervening muscles do not provide sufficient fixation for use with a long lever arm. Fixation of muscles indicates muscles that stabilize but do not cross the same joint as those being tested. For example, fixation muscles can stabilize the scapula and hip during movement but do not enter directly into the test movement. So it's important to stabilize the movable scapula to the trunk and the pelvis to the thorax so that the tested joint has a firm origin from which to pull. The anterior trunk muscles fix the thorax to the pelvis, and the anterior neck muscles lift the head forward when moving from supine to sit. Muscles that have an antagonistic action give fixation by preventing excessive joint movement. For example, the lumbricals and interossei fixate to prevent hyperextension of the MCP joint during finger extension. Specific knowledge of muscles and joints is necessary in order to perform accurate manual muscle testing. So, 1, it's important to know the location and anatomical features of the muscles. Number 2, you need to know the direction of the muscle fibers and their line of pull. Number 3, you need to be able to determine the function of the muscles, which includes synergists and prime movers. Number 4, you need to be consistent using standardized method of muscle testing. Number 5, proper positioning and stabilization techniques are necessary. Number 6, you need to be able to identify patterns of substitution. Number 7, you need to be able to detect contractile muscle activity during contraction and relaxation in very weak muscles. And number 8, you need to be able to compare contour and bulk to the contralateral side. Going on, number 9, you need to be aware of joint range of motion deviations and joint deformity. Number 10, do not grasp the muscle belly during manual muscle testing. Number 11, identify muscles with the same nerve innervation. Number 12, relate the diagnosis to the sequence and extent of the test. Number 13, modify testing when necessary without compromising results. Number 14, know the effect of fatigue on test results. And finally, number 15, know effects of sensory loss in movement. Now we'll talk about reliability and validity of manual muscle testing. Manual muscle testing is subjective, and generally results should be within a half grade of other clinicians who are measuring the strength. When the grade of the muscle is 3 or below, reliability declines. Reliability is affected by the experience of the examiner, the effort of the patient, the willingness of the patient to endure discomfort, the patient's ability to understand instructions, and the motor skills of the patient. Some terms that you need to know are resistance, break test, and point of maximal resistance. Resistance is the force that acts in opposition to a contracting muscle. Manual resistance is applied in the direction of line of pull of the muscle. The break test is the procedure used for manual muscle testing. It occurs at the end of the available range or at a point in the range when the muscle is most challenged. The point of maximum resistance in one joint muscles is at the end of the available range, and the point of maximal resistance in two joint muscles is approximately mid-range. In general, the point of resistance is at the distal end of the segment to which the bone attaches. For vertebroscapular muscles, such as the rhomboids, you resist with the long lever arm on the lower arm to reflect functional demands of these muscles that take weight of the arm into account. If there's knee instability, always resist above the knee and give a maximum grade of 4. For someone with transfemoral amputation, the maximum grade of 4 can only be given the patient due to loss of weight of the leg. Manual muscle testing goes from a grade of 5 or normal to 0, and there's 2 ways that can describe them. We'll go into this now. Grade 5 is a normal strength. Remember to first test the opposite extremity to the one that you're performing the manual muscle test on to know what that patient's normal is. The muscle action must be able to go through the total range of motion or the available complete end range of motion with maximum resistance. Grade 4 is also called good strength. Research has been performed with polio patients, and when they were tested and received a grade of 4, these patients had already lost 50% of their strength. Muscle group with a grade of 4, the person must be able to complete the full range of motion or the available range of motion against gravity and be able to take maximal resistance but gives at the end of the range. A maximal resistance with a break is considered a grade of 4. Grade 3 is also called fair muscle strength. The muscle group is able to complete the full range of motion against gravity without any other resistance. Findings from research with post-polio patients have found that a grade 3 indicates only 15% of motor neurons are still functioning. When you perform manual muscle testing, make sure that the muscle is not in a locked joint position, because this may appear that the muscle is stronger than what it really is. For example, when you measure elbow extension, don't allow the elbow to be locked into complete extension. And when you measure knee extension, do not allow the knee to be locked in complete extension when you test the muscle. Grade 2 is also considered poor muscle strength. In this, the patient can complete full range of motion in a position that minimizes the effects of gravity. This is called the anti-gravity position. This position is usually described as a horizontal plane of motion. Grade 1 is also called trace. This is when the examiner can palpate some contractile activity of the tendon when the muscle is attempting to function, but there is no visible movement of the muscle of the joint. To test a very weak muscle, the examiner moves the part which starts from relaxed position and then moves into the test position while helping the patient feel the movement and elicit a muscle contraction. Finally, grade 0 is when there is no muscle contraction that is visible or palpable by the therapist.